Tonight, I have decided to talk about some updates on new materials for the restoration of full arch rehabilitations. Something we all need to know that our population is aging. People are living longer. When I started practice, the average lifespan of a human being was around 75. Today, the average lifespan is 85. People are living longer and they're maintaining their teeth longer, and they have some specific needs as elderly. There is a rapidly increasing patient base, and there is an increasing complexity of patient care. These people that are living longer, when 50, they had some implants here and there. Now they're in their 80s. The implants are still there, but their natural teeth have given up. And they have some different needs than the young generation. And there's also an explosion of modern technology. And I'm sure all of you know that there's a lot of materials coming out on the market every single day. And we have to keep up with the technology, and it's a lot of work for us to do. But all these new materials are for our advantage. Materials are improving, techniques are getting better, the lab technicians are getting more sophisticated, and all of this is benefiting not only us, but benefiting first the patients, getting high quality dentistry. If you look at complete edentulism globally, you notice that more than 240 million people are partially and completely edentulous worldwide. But you notice that if you take a chunk between 65 and 74-year-old with a loss of natural teeth, you notice that there's a huge differences between the globes, between the continents, I mean. If you look at the North American continent, or if you look at Europe, Africa, Asia, or Australia, you notice that there's a huge differences. If you look at this, we know that 37 million Americans are completely edentulous, and 26% are between the age of 65 and 74. 30% are African American, 26% are Caucasian, 24% are Hispanic. But there is a wide range in edentulism between states. So for example, Hawaii have a 13% edentulous rate. If you go to Kentucky, it's 47. So you can't really generalize because every state is different. There's a huge population that is the concept it's wrong. There's a lot of people that need dentures, and there's a lot of people that will still need dentures. And it's important to learn the fabrication of dentures because you're going to have to start with making dentures if you want to pursue to get a hybrid. So edentulism, sure, and then we know that edentulism remains a challenge for the patients and for us, and it's a growing public health. Now, between 1988 and 2002, there was a 6% reduction in complete edentulism, but there is a steady need for treatment due to people living longer. Now, on the right side of your screen, these are all my patients, and you notice the youngest is 91 years old. And then among all of these, the majority are still living. We probably lost 5 of them. So again, people are living longer. Economically, affluent baby boomers account for 20% of the US population. These people have money, and these people are willing to spend their money on implants and on hybrids. And they are driving the future market growth. There will be a continued growth of edentulous patients, and then an increased demand for complete dentures in the next 30 years. In 2019, only 314,000 Americans underwent full arch procedures. So there is still room for implant fixed complete dentures or hybrids, but there's also still room for traditional bar restorations. And the reason why I'm saying that is because not every single patient can afford to have an implant fixed complete denture. Some of them, they can only afford a bar and an overdenture. That's why you also need to be comfortable doing that type of treatment. So if you look at the dental technology, The statistics are scary. There's only 14 CODA accredited dental lab programs that exist in the United States. And because of this profession's behind the scenes work, recruiting students is becoming very difficult. Now, if you look at this graph, you notice that the number of students in blue or dentist is getting bigger and bigger. And then look at the number of dental technology, it's getting lower and lower. So there is a shortage of qualified dental lab technicians. And that what mostly pushed the labs to go into digital technology and CAD CAM, and because you don't need that many people in your lab to work to do all these different steps that we used to do. So why did we go digital? Because you have a shorter production time, superior fit, less lab steps, decreased potential for errors, superior strength, superior quality, a repository of digital data that you can keep. So in case you need to redo something, you have the data in there, you just have to pull it out and then mill the crown or the denture again. There's a reduced treatment length for the dentist and a reduced number of interfaces. So for the digital prosthetic planning workflow, what you need to do is basically grab an impression, whether an analog impression or a digital impression, it doesn't make a difference. Now, the other thing is you need to do a verification jig. Now, this is crucial when you're doing all these full arch restorations because you want to make sure, or the lab technician needs to make sure that your cast is as accurate as your mouth. Because if your cast is not, and the lab technician is going to mill for you a framework for your hybrid or a framework for your bar, they might not fit intraorally. And because it's titanium, it's excessively, practically impossible to solder that material. In the old days, we used gold. It was easy to solder and adjust. But with titanium, it's, you have to make a new framework. So that's why the lab kind of requires a verification jig to make sure that your framework is, that your cast is adequate. Then after that, you need an angled abutment to adjust the access hole of your screw. The prosthesis is designed by the lab technician and mailed, and it's sent to you for trial. Now, after that, you're going to have to take a centric relation record, check the vertical dimension, and then make sure that everything goes on the right track from there. So the guidelines for decision makings are basically two. There are some functional factors that you need to take into consideration, but there is also some aesthetic factors that you need to evaluate to make sure that you're going on the right track. So when you get a patient like this, so first of all, it's very difficult to assess the vertical or the prosthetic space. Now, it takes a lot of work to get that done, specifically if the patient is partially edentulous, like this patient on the left side. Now, ideally, you want to get these teeth cleaned, and then once the patient heals, then what you do is you fabricate some wax rims, and then you can adjust the vertical space, and then get the lip support, and then figure out where the midline is, and all the other data that the lab technician requires to fabricate for you a decent trial denture. Because that trial denture is going to be like a guide for not only for the placement of the implants, but also for the fabrication of the final prosthesis. So the first thing you want to do if a patient is edentulous is start with the complete denture. So whether it's conventional or digital, and MicroDental can fabricate both. I have an excellent relationship with Rob Cryer, with whom I work on my digital dentures. And I highly recommend that you at least try it once, and you will fall in love with that digital dentures. And this is all what you will be doing, because that's all what I'm doing now in my practice is digital dentures. They can either be mailed or printed. This is a different topic now. I'm not going to get into that, but I am into the mailed system. I don't like the printed dentures for so many reasons, but we can't discuss that for now. I have published a couple of articles on that topic. If you have any interest, just let Mr. Sabelis know, and I will be more than happy to share with you the manuscripts. The first thing you do is data gathering Do you want the shade? You want the inter-alar measurement? You want to measure also the vertical dimension of occlusion, the vertical dimension of rest. And if your patient has existing dentures, you just use an alar gauge, an ALMA gauge, I mean, and then what you can do is get that number that you require. The impressions could be either made analog or digital. Then you send the data to the lab. Now, if you do analog, they have to pull the model and fabricate some wax trims that you have to adjust in the mouth, grab a centric relation record, and then from there, the lab digitizes your wax trims and take you to the digital world. And if you use digital impressions, the data is sent directly to the lab, and then the design of the denture is made. Then what you have to do is make a decision on the material. You want an iVotion dentin base or a simple iVotion. And the difference is the iVotion dentin base, the teeth are milled separately, the base is milled separately, they bonded together and they milled to final. The iVotion is a puck that has the white for the teeth on one side and the pink for the base on the other side, and the denture is milled in one piece. So it's a monolithic denture. Then after you decide on the material, the dentures are milled and they're polished by the lab technician and sent to you. Well, let me share with you how that functions. So this is a 3-appointment workflow, completely edentulous patient presented to the office and wanted to start the treatment on the spot. What I do is I use these Wagner universal impression trays. And basically, these are like a type of compound material, like the green stick compound. You put them in hot water, they become malleable. And all what you do is you mold them in the mouth. You can adjust them with scissors, you can border mold them, and you can use them with any impression material that you're comfortable. Now, I use polyvinyl siloxane, and then what I do is I make an impression for the maxilla and the mandible. I pull my cast, fabricate the wax rims, try them in the mouth, adjust them, and basically the lab technicians to take you from the analog world to the digital world, he's going to need some decent definitive impressions that you've made. He's going to put a cast and scan it, and the wax rims are going to be allowing the lab technician to virtually mount these maxillary and mandibular casts that he just scanned. So he wants to know where the midline is. He wants to know the lip support. He wants to know where the canines are going to be. And he's going to use everything to set the occlusal plane, select the landmark on the virtual cast, determine the outlines of the future denture, and set up the teeth. And this is done by 3Shape with the ivocolor type of teeth. These are SDCL teeth. You can use Phonaris teeth. You can use any teeth that ivocolor has. And then what you do is the software will allow you to position the teeth exactly where you want them to be. Now, the technician is going to share with you a virtual image of the future dentures. So all what you need to do is to look at it and approve it. And once you approve, then what they do is they take the puck, and this happens to be an A1 shade teeth with a pink base. And then what you do, you stick it in the machine. And then what the machine does is it starts milling the dentures, because the puck has the teeth on one side and the base on the other side, and it's going to be milling both at the same time. So here, this is the final stages of refining the teeth. The base has been already milled. So after that, all what the technician does is he takes the denture out from the puck holder and then cut the screws off, polishes the dentures, and send it to you. And this is what you could get. You notice that there's no junction between the teeth, the white teeth and the pink material. So there will be no debonding of teeth. There will be no staining of teeth. We did some studies at school that we realized that these monolithic dentures are very resistant to stain, and they're very strong. Now, you can tell me that what if the teeth break, patient drop his dentures, the dentures are repairable because this is PMMA. Contrary to printed dentures that are made of composite, they're not repairable. So a printed denture, if it falls on the floor and breaks, you have to make a new one. These ones are repairable. And this is how it looks in the patient's mouth. So CAD/CAM dentures have made it so easy for us. We can also use it with immediate cases, like if you have somebody that needs an ICD, that could be done. It could be done very easy. And the good thing about that, if a patient now decides to move forward, now because you have the data in the software, you can go ahead and you can print a surgical guide and then take it from there. What you need to know also in order to determine the aesthetics is you need to use the papilla meter and just to measure basically the distance from the incisal papilla to the border of the lip. And that gives you the residual ridge crest to upper or lower lip measurement. And then what basically it does is it tells you where the incisal edge of the teeth is going to be. Then you ask for the patient to smile. And when the lip retract, then you measure that too. And that gives you where the neck of the teeth needs to be. So you can give the lab technician an excellent measurement for them to know. So again, at repose, you determine if the prosthesis mucosal junction will be visible when they smile. Why is that? Because if a patient smiles, no teeth, and you can see the gums, that means if you put the implants on a hybrid, it's going to be a lot of gum showing. So at that stage, you would know that you probably would need to cut some of the bone to lift up the implants higher and to get the denture to go a little bit higher so that prosthesis mucosa junction is not visible. Anterior aesthetic tooth display helps determine the occlusal plane location. And then a lot of things play a role in the determination of that is the race, gender, the lip thickness, and the age. One way to measure if you have enough room for your hybrid, if a patient is wearing already a denture when he comes to your office, you can take some tin foil, put them on the teeth, and then when the patient grabs his CBCT, you notice that the opacity, the tin foil creates an opacity in the CBCT, then you can measure the distance from the incisal edge to the head of the implant. In that case, you notice that there was a 10.52 millimeters for the anterior, and posteriorly it was 15.31 millimeter. So this is kind of a quick way to determine that. The other way is to do it digitally. You grab a CBCT, impressions that you digitize, then you put everything in a planning software, all the details, and then you use a 3D printer just to print your surgical guide, and you can print also in temporary hybrid, and then go take all what you want from there. One other way to do it also is grab the patient existing dentures and get these speedy marks. These you can buy on Amazon. They're very cheap. They're just like $25 a box. So what you do is you stick them on the dentures, and then what you do, two things, is you scan the dentures alone, and then you scan the dentures when the patient is wearing them. So what that does is it gives you an image of the denture, and it gives you the bowls. You can notice in the CBCT, the bowls where the dentures were supposed to be. But because the acrylic does not show on the CBCT, so all that you're going to see is the bowl. So what you do now is you superimpose these, and then now what you can do is figure out from there, to figure out from there how much room you have from the incisal edge all the way to the bone. Now, the vertical space requirements varies depending on the prosthesis that you're going to be doing. If you're doing an overdenture with a bar, basically it's different than if you're doing a hybrid. The framework design also differs, but ideally, for an overdenture with the bar, you want a 17 to 20 millimeter of vertical space. Now, how do we determine that? If you look at the drawing there on the extreme right, you notice you want 3 millimeter of biologic width, 4 millimeter substructure. Sometimes they're plus or minus. You have a 3.2 millimeter for the locator for bar. You need 2 millimeters of acrylic on top of that in order not to break, and you have the teeth. So that's ideally how much you want. Now, if you're aiming for a metal ceramic implant fixed complete dentures, ideally you want also 15 to 20 millimeters. And then if you're aiming for an all ceramic, now it's totally different because you can go with a smaller vertical here, 14 to 16 millimeter. And the way we measure that is you get a 2 millimeter of biologic with 2 to 5 millimeter of pink material, and you have 10 to 11 millimeter of teeth. And that's how these measurements came about. The most important thing when you're doing all ceramic implant fixed complete denture is the connector size. I published a chapter not a long time ago with a friend of mine, and we looked at all the connector sizes that are available and recommended on the market. Now, we came out with our own, and we noticed that if you have 4 units or more, and you have 2 anterior pontics in the maxilla, you want approximately 7 millimeters square. But notice the more posterior you go, the bigger the connector size. So again, if you're too tight on vertical space, what's going to happen is you're going to have to make these connectors smaller, and that's what puts the hybrid into jeopardy and into a lot of load. So that again, it's extremely important to take all of these into consideration. Bone volume is extremely important. When you lose teeth, what happens is you have a palatal resorption and the reduction in height of the alveolar process. The maxilla resorbs centripetally, which means it shrinks, and the mandible resorbs centrifugally. And what happens is the patient is going to be in like a pseudo class 3 situation. So it's important that when you want to embark into an implant fixed complete denture, you have to look at that and how long has the patient been edentulous, mount the case on an articulator to be able to assess the relationship of implant to ideal incisal edge. Now, if you look at that patient, look where the maxillary bone is and look where the mandibular teeth are. So which means that if you put the teeth in a regular overjet overbite situation, you're going to have a huge cantilever, and that's what happened with him. It broke. So implant overdenture with denture flanges in that particular case would be more favorable biomechanically. So again, don't promise your patient anything before you do a little bit of a homework and a little bit of data gathering. So because you don't want to promise that patient, let's say, oh, I'm going to give you a hybrid, and then say, oh, well, middle of the way, you tell him, I'm sorry, I'm going to give you a removable denture. So they get mad at you. So look at the maxillary lip support, look at the facial contour, and then if you design an implant overdenture with flanges, you can get an ideal maxillary lip support because you can push the teeth as far forward as you want. Then the facial contour is going to get better. And also, you're going to reduce the implant overload because you're going to have a bar, and then the denture is going to be fitting on the bar itself. Now, that's what I told you. Meanwhile, you have to see how much gum display that patient has. Now, these people, what they did is they didn't even look at that. They fabricated the ICD, and the patient gets that, and she was mad. Well, of course she's going to get mad. Ideally, what you want to do with this is cut the bone, put the implant a little bit higher, and give yourself a good vertical space. So short lip to ridge distance is an issue. Visible prosthesis border is an issue, and border trap the lips. If it's too short, the lip is going to get caught into the border all the time, and the patient is going to have a lot of difficulties. The other problem with short lip to ridge distance is the lab technician is going to have to end up adding more acrylic on the buccal to hide the gums, and by doing that, making it for the patient excessively difficult to clean. You notice here the flanges are so high, patient couldn't clean, and he got into some other issues, tissue inflammation, and probably some bone loss. Let's talk a little bit about the number of implants what you need for an implant fixed complete denture. There is little evidence to support that implant number as a factor of patient satisfaction. Now, it's satisfying for us because we make more money, but for the patient, if you go with 4 or 6 or 8, it doesn't make a difference. They're satisfied the same way. So evidence does show that simple rather than complex designs that allow for ease of maintenance and cleaning are preferred by the patient. Patient prefer when they get older, they have dexterity issues, visual issues, they can't see much. It's very important for them to have something easy to clean. If you give them this sophisticated stuff, they're having difficulty to clean. So 4 to 6 implants have successfully been used in both arches. The anterior posterior spread and the cantilever is extremely important to look at also, specifically if the implant have been placed previously by somebody else and the patient presents to you, you have to look at this factor is very important. Recommendable, the recommendation that cantilevers may extend at most to 1.5 times the anterior posterior spread was empirically established. In a chapter that I co-authored with some of my colleagues, we did the research to find out how that number came to existence. Now, we found an article published in England, and that guy basically just didn't do any research. He just empirically put out that number. So it should be modified so that cantilever, should be modified by the estimated applied forces. Look at parafunction, look at skeletal form, look at the opposing dentition, and the number of implants. Now you look at these images here, the first hybrid on the left side, you notice that the cantilever are so big, and notice how on the buccal all the porcelain chipped. And then you look the one on the top, the implants are a straight line. And then these cantilevers are so big that they kept causing fracture of the screws. And on the lower one, on the right side, you notice that the cantilever is so inadequate that it broke the framework. So in the maxilla, it is very important to spread the implant in a way that you can only get 1 time the anterior posterior span. Now, again, ideally, if you push the implants a little bit more posterior, then you wouldn't need any cantilevers. If you can avoid them, it's much better. So that's why now we use tilted implants, and that expands the posterior anterior spread and pushes it a little bit backward to avoid using cantilevers. Or the best way is to distalize the implant as much as possible to avoid using cantilevers. Location and angulation of the implants. These are old cases. The one on the left side, I should say, is an old case. I understand they didn't have appropriate imaging at that time, and everything was done, by eyeballing. And you notice where the implant are and then where the position of the teeth is, and that creates a lot of cantilever. But the case on the right side is recent, and that was referred to me to say, please fabricate implant fixed complete dentures. And I look at that, but this is wishful thinking. The implants are placed, in such a bad way that there was no way I could use these implants. So again, there should be planning. The lab technicians now have all the tools and the programs and the softwares to help you design the implant placement ideally where they need to be able to give you a prosthesis that fits well, biomechanically is convenient, and doesn't put a lot of load on the implants. One such system is the Smile in the Box from Straumann, where they take your CBCT and they take all the information that you have, including a cast, including teeth and everything, or dentures, and they fabricate for you all what you want. A bone reduction guide, a surgical guide for placement of the implants, and then the interim IFCD, and again, they send you all the components. And then MicroDental can do the same. They can also help you design your cases in order to avoid any issues. Let's look now at the choice of framework design. If you want to go with hybrids, you can have some hybrid bars. These are fixed bar designs with an increased retention surface. You notice that there's either grooves, there could be some pins, there could be some T-bars, just to give you excess retention. Again, the design of these bars depends on the vertical space that you have. That's why the lab technician is not going to fabricate any of this if you don't have at least a trial denture that he can use as a guide, because he needs to figure out the height of this bar, but also he needs to figure out also, because you need some acrylic on top and the teeth. If you're going with a wraparound acrylic, but if you're going with a zirconia, it's the same thing. He needs to know how much vertical you have to be able to find out if this is feasible or not. You can also use the Preci VH bars or Freedom bars. These are for removable denture prosthesis. A couple of weeks ago, I did a beautiful bar with Rob Cryer at MicroDental, similar to the one on the right side, with an overdenture on top. These are very predictable, easy for the patient to clean because the bars are designed with a lot of room underneath to have the patient put a plexi brush or a water pick. And then the dentures that go on top is now, there's a housing that goes on top of the bar. And then the iVotion, which is a monolithic denture that Rob made, and then it's glued to the framework. And this way, everything is solid. The monolithic denture, there will be no debonding of teeth. That's what we had as a complication a couple of years ago. But now with the iVotion system or a monolithic denture system, this problem is solved. You can also have some telescopic bars or abutment hybrids. The telescopic bars is a bar with the housing on top, and the teeth are bonded to this. And then the abutment hybrid is a framework, and you have some zirconia teeth that are bonded, and then the base is either made of ceramics or composite. Now you can also have a cobalt chromium bridge for direct veneering. That means the lab technician will take that and veneers ceramic right on top with the pink ceramic at the bottom or composite. Just to show a case here, this is Johnny, was supposed to lose all his maxillary teeth periodontally involved. The first thing I did is get him an ICD. Once the ICD was done, then we started planning for the implant. I planned 4 implants in the maxilla, 2 in the premolar area, and you notice they tilted just in order for me to push that anterior posterior spread further in the back and avoid the use of cantilevers, or minimize them, I should say also. Now after that, a screw retained abutment was used, temporary cylinder placed on top, and the conversion denture was made. So I took his existing ICD and I converted into a temporary IFCD. And then once it's polished and its occlusion is adjusted and delivered. And you notice that there's a minimum cantilever, which is basically 1 tooth, and this is much safer for the end result. And once he healed, I made a definitive impression. Always grab an X-ray when you make an impression to make sure that the dentures are fitting. The impression copings are fitting on the implants, and the verification jig is crucial. Now, I don't care how you make your verification jig, but make one. Some people use composite, some people use Duralay, we use pieces of metal. So everything is okay, provided that you do one, just to make sure that what you have in the mouth is, what you have on the cast, is accurate and resembles what you have in the mouth. So this is the cast after the verification jig is done. The cast is scanned. The immediate, the temporary hybrid is scanned. And then after that, the lab technician is going to send me a temporary final just for me to have a look at it. It's usually helpful to establish the incisor length, correct the midline if it's off, or the cunt if it's off, because you don't want them to go to the final if you don't get one of these blueprint, at least to make sure that what you're going to get is correct the incisor line angles. It's going to help you correct the incisor and posterior planes if they're a little bit off, and gently test the incisal guidance. So once you have that, then the lab technician is going to finalize your case. And here, what they did is they designed and milled my wraparound bar. Studies have shown that CAD/CAM frameworks have been found to fit more accurately than cast with gold alloys. Now, in the old days, we always had to cut and solder because they will never fit. Now, don't forget, in the old days, we used to wax these bars and cast them, and along the process, there's shrinkage and deformities and everything. So we always ended up with some defects at the end. This is how, when you try it intraorally, and then the most important thing when you do that is do a one screw test to make sure that it's fitting properly, and we'll talk a little bit about that shortly. Then the lab technician is going to take this frame, and it's going to, here you see he scanned the temporary IFCD that the patient is wearing, and because I sent him a copy of that. And then he's going to mill from a monolithic block, Ivosian, he's going to mill for me the base and the teeth, and he's going to mill a recess in the intagliar surface of the denture where my framework is going to fit. So this is how it looks just after milling. There's no polishing, nothing that was done to it. And then this is the framework. So you see the framework fits very intimately in the intagliar surface of the milled Ivosian denture. The beauty of this is there will be no debonding of your teeth. And the other beauty, if something went wrong, let's say wear, let's say, I don't know, for any reason something fractures, all that you have to do is call the lab, they mill another one and then send it to you. So this is pre-op and post-op. And you notice when you do all your data gathering and you follow the basic principles of removable prosthodontics, there's no way you can go wrong. Aesthetically, it will look very nice. Now, framework must be fabricated from materials and protocol that allow passive and accurate fit between the frameworks and the implant. And that's why here comes they should be designed to resist tensile and compressive forces associated with mastication and parafunctional habits. So how do you do that? So what you do is, once you put the framework in the mouth, you tighten 4 screws or 5 screws, all the screws, then just by hand. Then what you do is you loosen all of them except for one. And then you grab an X-ray. And if there is a gap between the metal of the framework and the implant, that tells you that the framework has been under compression to fit in place. It's not fitting passively. What happens is when you loosen, the framework should be fitting on the implant. If you see any gap, that means something is off. Then what you have to do is you verify that your cast is correct by redoing a verification jig if you haven't done one before. So framework misfit can cause stresses not only in the implant, in the prosthesis and the surrounding bone. And you notice here, these are 3 different frameworks, and you notice that they're not fitting. That's why it's important to grab X-rays all along, and it's important not to move to the final before you make sure that the framework fits correctly. Don't rely on the screw to fit your framework on the implant. It's going to be under tension. And because of that, the implant is going to be under tension, and you probably will lose bone. Passivity causes the long-term osseointegration of the implant. So passivity is extremely important for your success, long-term success. So for the misfit, again, it's important to make sure that your cast is accurate. So what I do usually is I make an impression, and I make just a regular impression of the implants, and then I pull my cast, then put the impression copings on the cast, join them with the floss, either the relay or composite, whatever you want. Then you take that out and go back to the mouth and try to make sure if it fits. If it doesn't fit, that means your cast is wrong. But ideally, what you want to do is do the reverse. So which means put the impression copings in the mouth, bond them with the floss. I mean, put a floss around and put some composite or Duralay and let it set. Now, this is the jig that fits perfectly in your mouth. Then you take it out and go try it on your cast. If it doesn't fit on the cast is off. What you want to do then is take these impression copings, put them on the implants, and they bond it together now, and then make an impression with these. So not only you have the impressions of the tissues and the bone, but also a verification jig that fits into your impression material. So the 1-screw shuffled fit test does not work for non-planar implant connection. So, so how do you check the passive fit? You do a modified 1-screw fit test, like I just told you. So the framework on implants, all screwed in. Then what you do is you screw with the same torque from the center. So you start at the middle and you go, and then you tighten with the same force. Then you unscrew all of them except for one, and then you grab X-rays and check the the fit or the gaps on all connections without screws. And then this way you can make sure that you've got something that fits properly. So as a summary, it is important to master basic principles of removable and implant prosthodontics. The advantages of the digital workflow for clinician and dental technician needs to be understood. It is important that you understand that digital dentistry is very accurate, and it's your benefit to get into digital dentures and digital dentistry. Now, I understand that it might be a little bit expensive at the beginning as an investment to invest into an intraoral scanner, but long term, it's profitable for you and it's beneficial for your patients. Now, again, that's why also with digital dentures and any type of digital work that you're going to do, the communication with you and the lab is extremely important. You need to get that going much fluent. There should be guidelines for decision making. Again, if you want to do any type of work, an overdenture or a hybrid, an acrylic or hybrid zirconia, just make sure that you start from the beginning and then put for yourself a checklist that things you need to do. So check the vertical space. Patient, let's say, doesn't have a denture, you have to make a new denture, take it to the wax rims, and then either put some, if you want to go analog, put some teeth in, try it, make sure that it's accurate aesthetically, phonetically, the vertical dimension is correct, and then the technician is going to take you from there all the way to the other steps. If you want to go digital, you just have to stop at the wax rims. The lab technician is going to send you a printed trial denture that you can try. The only difficulty with the printed trial dentures is you can't move the teeth. The only thing you can do is shorten the teeth, mark the midline with a Sharpie pen, grind the occlusal plane if you have to adjust it. These are the kind of things you can do. Now, if you do some occlusal adjustments on it, or let's say you close the vertical a little bit, the lab technician is going to have to scan that and readjust virtually everything according to what you've done intraorally. That's why it's important also to communicate with the lab. Tell him what you did. Hey, John, I adjusted the occlusion. The flanges were too long. I shortened them in the retromolar height fossa. So he knows what you did, so he can rescan the dentures and adjust for the final one. And also, material-wise, again, you need to know where you're going. And the best important thing to know is you need to know how much it's going to cost you, because this is going to affect how much you're going to charge the patient. So imagine if you charge, let's say, $2,000 for an overdenture, and then what happens is your lab bill is $3,000. You're going to be paying from your own pocket. That's why it's important to kind of understand how much would it cost you, but all the steps from the components, if you don't have them, to the lab analogs, to the wax rims, and every single step, you have to figure these out to charge accordingly. And that's I see a lot of colleagues, they call me and they say, well, I was surprised the lab bill was that expensive and I didn't charge enough. So again, you have to do your homework and to figure out how much all of these things cost you so you can charge accordingly. And again, and we sometimes forget that if you don't do implants, there's the cost of the implant and the surgery and then the surgical guide, so that adds up. So that's why it's important that you have a very honest communication with your patient. Say, okay, my fees are going to be this much, and then you have to add to that the surgical fees. And sometimes patients will look at you and then they roll their eyes and they'll could buy me a new car. That I understand, but you have to pick your priorities. And again, if you plan if you plan your case, you won't get into any hurdles. People get in trouble because they never do the initial homework. And the initial homework is the understanding of complete denture prosthetics. And that's why at the beginning I started with that, just to make you aware that you still need to learn how to do decent dentures. You still need to know the basics. And so this way you won't get in trouble, and then you have a very nice, fluent conversation with the lab technician. With this, I just want to thank all of you. If you have any questions later, you can email me, nbaba@llu.edu. I won't promise you a quick response, but I will respond to you. And you can follow me on Instagram, on Facebook. And with this, I'll be more than happy to entertain some questions if you have any.